Fantastic. All right. Hey, welcome everybody. It's cancer. It's been a minute since our last podcast. We've all been working pretty hard, but we're excited today to take on the subject of gallbladder cancer. And with it, we've got some special guests. Of course, we got Michael Reardon, our everyman here, who's there he is, and
Not a
Dr. Eva
doctor.
Galka, not a doctor, but plays one on this podcast.
No.
And Eva Galka, who's a surgical oncologist, and Maria McGreevy, who's a medical oncologist. All right, if you guys would, just for like 2 minutes, just introduce yourself, starting with Eva.
Okay, I'm a surgical oncologist at the University of Rochester. I specialize in all GI cancers, liver, pancreas, gallbladder, what else? Any GI and gastric cancers. And I also take care of melanoma and sarcomas. So I'm a bit of a jack of all trades, and I am happy to be here.
Awesome. Thanks, Eva. And Maria.
I'm Maria McGreevy. I'm a medical oncologist also from the University of Rochester. I take care of patients with GI malignancies that Dr. Galka mentioned, plus esophagus and colon. I'll add to my repertoire. I also help to care for patients in our hereditary cancer screening and risk reduction program. So those that are at an increased risk of cancer, helping to hopefully prevent or find early cancers when they're more treatable.
Awesome. And Michael, how'd you get roped into this? A good man like you.
It turns out that I have all of the body parts that were just mentioned. I have an esophagus and a pancreas. And so I'm here as the everyman to keep the doctors from sounding too doctory, to remember that they're talking to someone who, like me, doesn't always know what they're talking about. So that's here.
All right, well, let's begin at the beginning. Maybe this is a question for Eva. In terms of talking about gallbladder cancer and biliary tract cancers, I think we'll just focus on gallbladder today, if that's okay. What is a gallbladder? Where is it? What does it do in normal circumstances?
So I like to say that the gallbladder is a useless organ, and it is located in the right upper side of the abdomen. It is it's almost like a balloon that hasn't been inflated. And its job off a little bit of the bile that is made by the liver. So the liver makes bile, which is like soap detergent, and helps our body break down our fats into smaller pieces so that they could be absorbed. And the gallbladder is coming off of the bile duct, which is a little tube coming from the liver that heads to the bowel. And the gallbladder is coming off of that, and it really does siphon some of that bile while you're not eating, so that when you are eating a very fatty meal, the gallbladder is told to give a little squeeze and give a little extra of that bile. And it sounds wonderful, and it was, I would say, perfect in our caveman era. However, the way we eat and the foods that we eat, we don't really need it. So the liver is making the bile, and it's passing all the time. And it really, unfortunately, it doesn't work perfectly. So the gallbladder doesn't empty entirely what it has. And because of that, the bile gets to sit there for some time. And because bile is actually made of salts, and salts just in the right composition will form stones, and are therefore always there, and they can pass through the system and get stuck in various places. Those gallstones are the cause of acute cholecystitis, or inflammation of the gallbladder, and they can get stuck in the bile passageway and cause much more serious problems, and they can get caught in the system that empties the pancreas and cause pancreatitis. And then unfortunately, we believe that gallbladder stones can eventually cause so much inflammation that they might be one of the causes of gallbladder cancer. And so, I like to tell people that you can live without the gallbladder, because again, the liver is what makes the bile, and the bile passes through the system without the gallbladder at all. So those of us that are missing a gallbladder, or those of you that are missing a gallbladder, don't really need it. And then unfortunately, gallbladder cancer is a very aggressive cancer that many times we don't find early. But if we find early, we can cure. But unfortunately, sometimes we find late, and then it's very advanced, because gallbladder actually is attached to the liver. And so when it is very advanced, it can invade into the liver or into the bile passageways, and that's when it's very aggressive.
Awesome. So the way I like to describe it, thank you very much, is it's like a little bag or purse, and your liver is this sort of wedge-shaped item in the upper right part of your abdomen, and it's kind of the major factory for your body. And this little bag is stuck underneath. Do you remember hide a keys when you're trying to hide your key and you can stick it under something? It's just sort of stuck on the undersurface of the liver. And it's a little bag, and it holds the bile until it's time to squeeze it out. And just like you said, it causes all kinds of problems. It did put my kids through college, so I can't say it's entirely useless, but it causes a lot of people a lot of trouble. So Maria, if it's all right, can I ask you, in terms of how does a good gallbladder go bad? In terms of the development of gallbladder cancer from an ordinary healthy gallbladder, is that something you'd feel comfortable taking on?
Yeah, sure. I think some of it's kind of bouncing off of what Dr. Galka said in terms of things that we can associate, at least, with gallbladder cancer development. The most common being stones, like Dr. Galka mentioned, and that them being there and causing problems. Most commonly, that inflammation, longstanding inflammation, we know in a variety of different cancers can increase the risk of cancer development. So that's one of the most common things we see. And folks that are diagnosed with gallbladder cancer is that they have a history of stones, or we find stones at the same time as that we're finding the gallbladder cancer. Other things that cause chronic inflammation in the gallbladder can be infections, some of which are present in the United States, some of which are more common in other parts of the world. So gallbladder cancer in the US is a relatively rare cancer compared to the frequency in other areas of the world. And some of that is due to differences in infection that can be seen in these other places. Some chronic autoimmune type diseases that affect the bile ducts in the gallbladder can also increase the risk of developing a gallbladder cancer, again, for that same reason of the inflammation being present. And then I think there's a whole host of things we associate with many types of cancers, like obesity, diabetes, smoking, that we see higher incidence of. And a lot of times I think it's probably more than one thing that leads to the development of gallbladder cancer. And we never are able to point our finger at one particular thing a lot of the times. And people always want to know, why do I have this cancer? And it's a tough one to answer. Sometimes there's an obvious reason, and other times it's you kind of make up a reason based on all the things that I just mentioned that it could be.
Sometimes it does seem just so completely random that this person, they're just living their life, not even jaywalking across the street, just doing everything right, and it happens. But usually, my sense is there's always some chronic inflammation at the start, or a hereditary issue. Let's get to the
I have
hereditary
two
part
questions.
later.
You can't move on without me. No,
No,
no.
very good. Very good. Very good.
I have two questions. So one of the first would be, Maria, you had said that it's a lower incidence in the United States, which leads me to believe that there are environmental factors at play. And what are those environmental factors? Do we know?
Yeah, that's a good question. I don't know if it's so much environmental versus the type of exposures to endemic infections is more of my understanding of what the cause is. So infections that are more common in other areas of the world, like salmonella, or even some of the H. pylori type infections that are more common in other areas that we just don't have as much of in the United States, is really what kind of
So
triggers the higher rate in those places.
bacterial infections.
Mm-hmm,
Okay,
mm-hmm.
that's
Yeah,
interesting.
and
There's also a parasite, Clonorchus,
Mm-hmm.
which can destroy the valve at the base of this system that then promotes bacterial overgrowth. But I'm not sure where is that, like in the Middle East where people get Clonorchus?
well, the most common incidence is in Chile, in South America.
For
So I've always thought of it as part of it must be the environment and clearly genetics that we don't know, right? We don't know that part of the genetics, but there has to be an association with some kind of food, which is likely bacterial, and the way that food in that region is prepared or saved or cultivated, if you will. But it's very interesting that one of the most common locations for gallbladder cancer is Chile, whereas in America, our most common cancers, breast, prostate, and colon, lung also being up there, which is very interesting.
So thank you for that. And my second question is the one, probably I'm jumping ahead, but if it's difficult to detect or it's rare, especially in the United States, and you hope to catch it early, I know from the earlier podcast that we did that one of the single best things that I can do is attend my yearly checkup. Is this one of those cancers that will be picked up in a simple blood screening? Like I'm always getting my blood pulled and tested, or not? Or is there anything that I can kind of test for ahead of time, keep myself safe? I
Maria, I'll
stumped
let you
them.
go first.
No,
Yeah.
no, no.
Sure.
Yeah. So unfortunately, there's not a blood test. I think at some point in terms of all of our cancers, we're hopeful that we'll get there someday, that we're able to detect all cancers, certainly at the earliest stage, and maybe with a blood test that's not invasive. But we're certainly not there yet. I think picking up on some of the risk factors at your sort of annual PCP visit, in terms of the things that we talked about. Do you have any signs or symptoms that there could be something wrong with the gallbladder in terms of, do you have pain after eating? Do you have pain in that area on exam when your primary care doctor is examining you? Can give a tip or a sign that something's off. Certainly lab work can look at some liver numbers in terms of, is there something abnormal there that may trigger additional imaging, but there's not one test right now in terms of a blood test that will find it. I think it's more going to that annual checkup like you mentioned, in terms of what are your symptoms, what's your exam like, and what are just the basic labs tell us that might trigger somebody to think about this. But it's hard. I think that's what Dr. Galko was mentioning earlier, is that it's a difficult cancer for us to find early, because where it sits, there's not a lot of symptoms until it becomes a problem. And sometimes it can be too late at that point.
So I think this segues nicely into the patient that has gallbladder symptoms, right? So Paul and I have met many a patient who will have right upper quadrant pain, and then they get imaging and there's an ultrasound that shows that there are stones, and they're referred to a surgeon, and they're still having pain or recurrently. And so they want their gallbladder out. And we may find on the gallbladder removal and pathology report a gallbladder cancer. Those are the early ones. But then likewise, Paul and I have had multiple patients who will have had pain. It went away. They were evaluated. They had stones, but they no longer have pain. And so they don't want their gallbladder out. They don't want surgery, right? Like, who wants
Who
surgery
could
if they're
blame
not
them?
feeling?
Yeah.
Yeah, exactly. However, almost every single patient that has gallbladder cancer has had, and so that could be purely associational. We know that it's not necessarily causative. However, we also know that chronic inflammation, like Maria said, other cancers causes cancer. This like Crohn's disease, inflammation of the bowel. People with inflammatory bowel disease have a higher risk of colon cancer. So without anything else being equal. So there is this belief that chronic inflammation from chronic stones causes cancer. And certainly the recommendation is, if someone has a stone that is greater than 2 to 3 centimeters in size, and that takes time, they don't occur like in a minute. That takes years for those stones, tiny stones. First, it's crystal, and then it's then it's sand, and then they become stones, and then they become stones that come together and form this big stone. If someone has imaging that shows that a stone that is 2 to 3 centimeters in size, and they're sent to me, I will really strongly advise that gallbladder be removed.
Yeah, me
Again, I've
too.
told you, I don't really think you need to. We need it in our everyday kind of 2020
Function. Yeah.
function. Yeah, we don't need it to function. And so I will recommend it. But at the same time, the general recommendations for a patient who has gallstones, small, but gallstones, who has no symptoms, is not recommended to have their gallbladder removed. And again, they don't have any symptoms, and so they don't want surgery. However, that might be something that we can perhaps change, because of this risk.
I think that's a good point. When I'm talking with somebody who's got gallbladder stones, gallstones, if you dive deeply, most of the time they have abdominal pain. They eat and then it hurts, and so.
Or they will say, the folks that don't like to ever claim they have pain will say, well, I avoid these foods, right?
Yeah.
And I say, why do you avoid those foods? Well, because they make me feel bad. It's not pain. But, so there is this American idea that cancer causes pain, right? And when you have pain, that's when you go to the doctor. It's not when you feel a little bit of discomfort or when you have some nausea or I'm avoiding all these foods. It's only pain. That's one of the things I really want the public to understand, that it's okay, first of all, to call it pain. If you want to call it discomfort, fine, okay. But if you're avoiding foods, then something's wrong.
Yeah.
What does
Well,
that look like to someone like me? Like if I'm experiencing some pain, what are my peers showing up and presenting to you with that I can take something away from? Like it's that funny feeling.
typically, if there's trouble with the gallbladder, whether there's a stone in there or it's just not squeezing very well, and if you think about its role in digestion, it all makes sense and it's easy to remember, which is, we're going to eat this food and the food needs to get broken down into little pieces so that it can get absorbed. And the gallbladder is going to coat the food with that chemical called bile in order to break it down. And it's a strong chemical. So you're going to eat, and then 15, 30 minutes later, and it catches your breath and it hurts, maybe up in the middle or
So
upper
it's a
right.
severe pain. It's not like acid
It's a
indigestion.
it's a
something different.
scale. Some people, it's the worst thing ever. Other people, it's just a sense that something's really wrong and it's not quite on the pain scale, but it's nausea, and then it goes away. But
So there's pain and nausea, and it's local to that
yeah,
gallbladder area.
it's upper midline or upper right, and it
Mhm.
lasts 30 minutes to a couple hours. If it lasts any longer, you'll be in the ER for sure, even if
All right.
it's, but
So kind of up under the ribs and over to the right or
yeah.
midline. Okay.
Yes.
And then the way the gallbladder, I've got a few notes if you don't mind my reading. One is just on the epidemiology of gallbladder cancer. It's highest in India and in South America, somewhere between 10 and 22 per 100,000 in India and 19 to 14 per 100,000 in South America. Eastern Europe and Asia are less, like 2 to 8,000 per 100,000. USA, it's only 1 to 2 per 100,000. So it's a little bit lower. And it's maybe the 6th most common cancer of the GI tract.
So when you're saying
Now-
1 to 2, you're actually saying 1 to 2,000 or 1 to 2%.
1 to 2 out of every
100,000.
100,000. No, just
100,000.
1 to 2 cases every 100,000 per year.
So 0.2%.
Yeah. And we covered all the other issues, the mechanical injury, the bacterial colonization, chronic inflammation, bacterial and parasitic, chemicals such as pollutants and chemicals.
Wait
and
a minute,
tobacco.
Paul. I got to check your math here.
Yeah.
It's 1 to 2,000.
No, 1 to
Out of
2.
It is just 1 to 2.
2.
You had waffled on that. On some of them you said 1,000, some of them you didn't. So I was clarifying. So it is just 1 to 2 people out of 100,000.
Yeah, per year.
Okay.
Yes.
So it's
In America. Yes.
It's pretty rare.
So well below 1%, but
And then,
still to be taken seriously.
yes, well, it's enough that, the three of us physicians see it pretty regularly. And the two basic categories is it's an incidental finding, meaning we just discovered it when we were taking it out, or we knew before surgery that it was a cancer. So incidental, we're just like, oh, you've got gallstones, I'm going to take it out. And then either in the operation or after the operation, when it comes back from the laboratory, you're like, that was a cancer. Then the other realm is a person has some issues, we get some imaging, and right up front, we're thinking, oh, this is gallbladder cancer. That's a more advanced, typically. And so let's get to the treatment. Do we want to start with Maria or Eva on overall strategies for how you treat a gallbladder cancer?
I can take it first. So in general, as you mentioned, the more common scenario in America is that someone has gallstones, they have abdominal pain, they see a surgeon, they get their gallbladder out, and the pathology comes back 2 weeks later and it says there's a cancer. And so in that case, we want to know what is the depth of invasion within the gallbladder wall. So the gallbladder has 4 layers, if you will. Most of the bowel has that as well. And you want to know how deep has it gone? How many layers has it gone through? And the next most important thing is hopefully your surgeon has removed one of the lymph nodes that's very closely attached to the gallbladder so that we know, is there cancer in the associated lymph node? And then lastly, is there cancer in the little, I said it looks like a balloon. So that very end that was cut, is there cancer there? So you can kind of define gallbladder cancer in its relatively early stage because the lymph node's not involved. The margin, which is the edge of where you've taken the little passageway, is not involved. We call that the cystic duct. And the it hasn't gone all the way through the 4 layers of the gallbladder wall. And so those in general, if all of those are negative, then we have a relatively early stage cancer. And we can talk about treatment in a second. But first step is gallbladder's out. All those things are like clean, if you will, but there is a cancer. And so we have a pathway for that. The other scenario is that this patient came in and they had severe pain and they were imaged, and now they have this mass in their gallbladder and it's involving the liver. And in that case, we want to make sure that it's only involving the liver nearby, that we need further imaging to make sure there's not involvement of lymph nodes that are surrounding both the gallbladder, pancreas, kind of all of these structures that are nearby. And if they are not involved, then we'll kind of put them in that first boat where we'll still think about a surgery up front. However, if the lymph nodes are involved or there's really extensive involvement in the liver, then perhaps we'll bring it to a conference, multidisciplinary conference, where we have our medical oncologists, our surgical oncologists, our pathologists looking at our radiologists, and we all kind of put our brains together and say, okay, this looks a bit more advanced. Perhaps this patient should get chemotherapy first. And then we may also have the patient who comes in, they're having pain or not, but they are yellow. And that's because we worry that there's something wrong with the bile duct, which is the main passageway from the liver passing the bile to the bowel. And now we're concerned there's involvement of the bile duct, and there's many things that could cause that. Stones in the bile duct could cause that. A cancer in the bile duct could cause that. A cancer in the liver could cause that. And a gallbladder cancer could cause that. And that scenario is much, much more advanced, I would say. And so we'd want, again, multidisciplinary discussion, but full images, make sure there's not these disease outside of that space. And again, our medical oncology colleagues would be probably the first to kind of treat that patient, and we could consider further like possible surgery. And I guess the last, I like to call them buckets. Like these are little buckets that people would be placed into, and then our treatment is based on kind of the bucket. And the last bucket would be that patient that came in jaundiced, maybe not jaundice, but a big mass in the liver from the gallbladder and spread elsewhere. And that would be someone who chemotherapy would be perhaps offered, but surgery would not really benefit. That would be kind of the initial discussion, if you will. I'll let Dr. McGreevy expand a bit on that.
That's great, Eva. Thanks so much. So
Wait. She was expanding.
surgery, I was going to give it to Maria. Yeah. But surgery, if you just do surgery alone, that cures only the earliest stages of this, and for everything else, it's Dr. McGreevy here. So there's been a lot of development in the medical treatments for gallbladder and biliary tract cancers, really exciting developments. And so let's turn it over to Dr. McGreevy here and see what kind of, treatments she has in her bag of tricks for people with gallbladder cancer.
Yeah, so I totally agree. I think this is an exciting space. Unfortunately, a lot of the
Exciting
excitement right
space for
now.
doctors. I just want to clarify.
That's it.
No,
It's
you're
a
right.
terrifying space for the rest of us.
No, but new treatment options
Completely.
is a
That's
good
true.
thing,
That's
certainly
a
for everyone.
good point. Yeah.
Unfortunately, where new treatments often come in first is in the metastatic setting, or when the cancer has already spread, is where we often bring in new cancer drugs. And so that's right now where all of the new treatments are coming in terms of treatment for gallbladder cancer. And over time, we kind of slowly move them into treating earlier stage cancers. So I think, like Dr. Galko was explaining, when I meet a patient with gallbladder cancer, my first question is always, is this something a surgeon can take out now or not? And there's kind of two different paths that we go down. If this is something that can be surgically removed, then we know we need to do surgery first. But surgery in and of itself is not enough, we think, to cure people of gallbladder cancer. The risk of it coming back is high enough that almost for everyone that has a gallbladder cancer and has surgery, we talk about chemotherapy afterwards as a way to lower the risk that the cancer comes back. And sometimes people wonder, why am I getting chemotherapy if you took the cancer out? And the reason we think about doing that is because of, with any type of cancer, there's a risk that before the surgery, there could be single cancer cells that escaped from that surgical field or that area that was removed by the surgeon. And if even a single cancer cell is left behind, there's a risk that it could kind of go and set up shop somewhere and come back and affect that person down the line. And so, what we've learned over the years is by giving chemotherapy after surgery, chemotherapy works by killing those cells that grow quickly, which are cancer cells. So, if we give chemotherapy for a period of time, our goal is we wipe out those cancer cells that are remaining to help lower the risk that that cancer ever comes back. So, for people that have had a gallbladder cancer removed, typically we're talking about 6 months of chemotherapy with an oral medication that they take. Sometimes we intensify the chemotherapy and we'll give 2 chemotherapies, and we'll talk about doing radiation. And that's largely dependent on what we see at the time of surgery and multiple factors, like Dr. Elko was mentioning, in terms of how far through the wall did the cancer seem to grow? Are there lymph nodes involved? Are there margins involved that help us to say how high risk is this to come back, and how intense do we need to be with our chemotherapy choices? I'll pause there in case there's questions, Michael.
Well, so it sounds like because when we first started talking about this, and I know from talking to Paul on other, he loves to cut. There are other cancers where you cut it out that like you're done, right? So I was thinking this is, oh, well, you're cutting it out. And Dr. Galka had already said, yeah, I would recommend if they have stones, I'm just recommending that they take it out because don't need it. And so I thought, oh, that's problem solved. But you're basically telling me in this case, we're going to dose it with chemotherapy basically because we can't really guarantee it otherwise.
Yeah, the one thing I didn't mention is that the gallbladder removal only, cholecystectomy alone, is only beneficial in the very earliest stage of gallbladder cancer, which is stage 1. So it's only reached like just past the first layer to the second layer, not encroaching the second layer. So just the first layer, I should say, to clarify. There's actually more surgery that would be recommended after imaging. So you take out a gallbladder, you find out there's cancer, you find out what layer it's gone through. It gives us a stage. If it's the very, very earliest stage, then taking out the gallbladder alone is good enough. I still would send that patient to Dr. McGreevy. We'll have it on a multidisciplinary conference. Unfortunately, most of the gallbladder cancers that we find have actually been more than just that initial layer. It's deeper. And so there are kind of very difficult nuances to explain on a podcast. However, if you are at the second or third level, but you haven't encroached into the liver itself, the next step, I would see that patient. I would tell them this is still relatively early stage, but probably stage 2 based on what we're hearing. We'll do imaging, make sure that there's nothing else anywhere else. And then the recommendation will be to take a partial liver resection. The gallbladder is really, like we said, like this balloon, this purse sitting like attached to the liver. So we want some more margin. So it's a partial liver resection of 2 segments of the liver that the gallbladder is attached to. Actually, the way that the liver is described in segments, or defined, if you will, by segments, it straddles segment 4 and segment 5 of the liver. And then removing all of the lymph nodes that are around the region. There are no lymph nodes in the liver. However, the passageways to and fro the liver are filled with lymph nodes, usually 5 to 10, I would say, on average. And we want them all gone to make sure that there's no disease there. And so that is a procedure that I previously did open, but now we do robotic assisted. And in general, the patient stays one night and is able to go home the next day, which is really remarkable.
Big difference.
Yeah, it's a
Yeah.
huge difference. Similar to gallbladder surgery open versus gallbladder surgery laparoscopic. And that gives us margin so that there's no further disease that is locally going to occur. And then that gives us a lot of information of, has it spread to these lymph nodes, which helps Dr. McGreevy and our medical oncology colleagues decide chemotherapy or not. And I'll say just quickly, I know, Maria, that we give everyone chemo now. However, early on, we didn't know, right? Who to give, who to not. So we, as chemotherapies improved, as she mentioned, we kind of moved it from metastatic disease to now, okay, this is a good chemotherapy. Now we're going to give it in people who have less aggressive disease, but we still know it's aggressive. And so we're giving it now in almost everyone, right? Like now I send everyone to medical oncology, whereas previously I would not send someone with the earliest stage. But getting those lymph nodes and making sure they don't have disease helps us all feel that it's appropriate to give further therapy, because we know that surgery alone is not good enough.
And Michael, I think like 2 points worth pointing out is one, so much of the action with this type of cancer or any other happens at such a small microscopic scale. It's just hard to get our minds around how it is. Like a cell, a cancerous cell, is so tiny that it takes 20 generations for you to have a block of cells the size of the tip of your finger. It only takes 10 more generations until it's a 10 by 10 by 10 centimeter block, which is enough cancer really to be a lethal process for anybody, no matter what type. And so by the time the thing is a cubic centimeter, the tip of your finger, it's already 20 out of 30 generations evolved. And so the other point is that, people always say, oh, we're 2/3 water. And it's true. All our cells, it's not, there's a lot of water in and around all of our cells. And these little cancer problems move through the water, and your lymph nodes, while we keep talking about them, they're little water filtration plants that are posted all around all our different organs. And so tumor cells will tumble through the water and through the circulation to this little water filtration plant. So that's why, whether we're talking breast cancer or colon cancer or gallbladder cancer, we're always obsessed about these little lymph nodes, because we want to know, have those cells managed to detach from the mothership and tumble down into this new area. And so it matters if there's a single lymph node that's positive, and it matters if there's 5 versus just 1. And so anyway, back to Maria. Let's say you have a patient with a cancer and it's going to get treatment from you. You have chemotherapy? Do you have immunotherapy? How do you decide who gets what?
Yeah. So for patients that we're treating with curative intent, they've had their surgery, there's no evidence of disease elsewhere. Those are the folks that typically just get the chemotherapy, like I mentioned, or sometimes chemotherapy plus radiation. Where we start using more of the tools and treatment options that we have are once the cancer has spread or it's metastatic or stage 4. And all of those people right now will get a combination of chemotherapy and immunotherapy as sort of their first line of defense for treatment. The chemotherapy, like I mentioned, works by killing cells that grow rapidly, which is cancer, but unfortunately are a lot of normal cells in our body. And so that's where people get side effects from chemotherapy that many have heard about, like fatigue and nausea and mouth sores and hair loss. Immunotherapy has become a very powerful treatment options for many cancers. And more recently, gallbladder cancer in particular. It was just 3 years ago that we started using immunotherapy as a sort of standard in this setting, and we combine it with chemotherapy. And the way that immunotherapy works, and this is why it works in many different cancers, is it helps to stimulate your own immune system to find things that shouldn't be there. And so our immune system, we know, works all the time to find bacteria, viruses, things that shouldn't be in our body. Cancer is another thing that shouldn't be there. And so by kind of taking the brakes off the immune system, immunotherapy is able to recognize the cancer as something that doesn't belong there to try to treat the cancer in that way. So we use the combination of chemotherapy along with immunotherapy to kind of hit the cancer in multiple different ways. And we found when we use that combination, instead of using just chemotherapy by itself, that we get more cancers to shrink and we help people to live longer. And ultimately, it gives us a treatment where eventually we can stop the chemotherapy. We usually only do the chemotherapy for about 5 or 6 months and then stop it and then continue with just the immunotherapy alone, which tends to have a much better side effect profile. So people aren't as sick when they're just getting immunotherapy by itself.
And are you notice? Oh, sorry, Michael. Looks like you have a question.
I was just, what are my survival options at at the different stages? How much time do I have at each one?
Yeah. So it very much depends on the stage, like you just mentioned, with very early stage gallbladder cancers, where we're talking about a potential of curing somebody of gallbladder cancer. If it's in its earliest stage, we're talking maybe 70, 80% chance of cure. If it's, again, that very early stage. But even when we have a gallbladder cancer that we've removed, if there's lymph nodes, for example, that are involved, there's probably over a 50% chance that that cancer comes back. And that's why we talk about doing chemotherapy to lower that risk. And I think where prognosis, or how long do people live with gallbladder cancer once it's already spread, is an answer that we have a little bit, or is a question we have a little bit more clear of an answer on. And when I meet people with metastatic gallbladder cancer, I often say that if we did nothing, because this is a fast moving cancer, that the cancer could take your life on an order of months. But with the treatments that we have, our goal is to really extend that time and to make quality of that time. So we want to make sure we're picking a treatment that doesn't make people miserable, but can also help to give them more time, but a good time that they have. With our treatments that we have now, and a lot of this is dependent on things we haven't talked about yet in terms of what the makeup of the tumor is. But on average, we can help people with metastatic gallbladder cancer live a little over a year with treatment. But that can be extended longer, again, depending on some of the newer treatment options that we have based on the molecular makeup of the tumor itself.
If you catch it at the earliest stage, do I have my whole life ahead of me,
Yeah.
barring a
So when
bus?
I say cure, that means that people are living 5 years without the cancer coming back. And when people make it to that point, we say it's unlikely that that cancer is ever going to come back. So in those early stages, the cure rates can be as high as 80%. So then we would say, yes, you're likely to have a full normal life if we can get you to that 5 year mark and not ever see the cancer come back.
Yeah, and I know where you're going with this, Michael, because I think I know how your mind works. Where you're like, okay, what am I going to tell my primary care doc? He's like, I'm going to make up some gallbladder symptoms just to get rid of it, to take it out. But I think a theme that comes through for every episode is that if you see something, say something. If you're having physical issues and if you do have access to medical care, you should use it and have a relationship with your primary care doctor and let them know. Because if you can get that gallbladder out while it's a problem but not yet a cancer, then you never have to worry about the cancer. Or if you get it out and it's an early stage, then either between Dr. Galka or Dr. McGreevy, you got an 80% chance of cure, 4 out of 5, which is pretty good odds. But if it gets farther down the road, it gets harder and harder to cure.
Well, that is, I know we've done enough of these, and I ask the same thing every time, but it has really pointed to go to the doctor, get those annual checkups, because even if nothing else, that creates a baseline that then when you are starting to have pain, like they already know you, as opposed to like men like myself who don't show up to the doctor until they have that pain. And then the doctor, they don't know you, and you don't maybe even know yourself medically. So yeah, like just getting in there and having those conversations, they get to know your baseline. And then when something is amiss. So yes, I'm a big proponent of saying that every time.
But no,
Go to
it's
the doctor.
great.
No, I
It's a
think that's
really
really
important point.
important. Absolutely. And I think the other thing to tell people is that, you don't have to have the worst pain of your life to actually tell someone that something's not right. Right. I mean, we clearly all have seen the patient that every little thing gets
Yeah,
reported. But I also have the patient that refuses to call gallbladder pain
yeah,
pain, right? I don't feel well. I'm ignoring that food. So I have come because I get people, I'm a cancer surgeon, but I see plenty of gallbladder, like benign, non cancerous gallbladders. They're usually the worst of the worst, but if they're sent to me, I'll see them. And when people come in, sometimes they're like the old veteran who just had their gallbladder like hospitalization because they had pancreatitis and now they're better, or they had acute cholecystitis and now they're better, and they're like, I don't know why I'm here. I'm better. And I have to say, take a step back. Okay, so you don't have any pain now. Well, what do you ignore foods? Like, do you avoid things? I have to do the negative questioning, if you will, and then explain, well, if you had that complication, then it could happen again. And next time it could be worse. And so you should have your gallbladder out. And oh, by the way, this didn't happen yesterday. This is a chronic disease, and there is an association with gallbladder cancer. So get
I
your
just took a
gallbladder out.
gallbladder out on Monday, and the poor fella had been suffering for a year,
See,
constantly. His girlfriend was there, and she told
that
on
doesn't
him.
sound like a long time to
A
a man.
year. I am not that tough. Hey, so Maria, how much has the treatment for gallbladder cancer, the surgical treatment hasn't changed an awful lot, with the
Yeah.
exception that the medical treatment got even better. And so sometimes now what we can do, I can think of 2 patients where you can give the medical treatment up front and then the thing actually shrinks, which I never saw until just lately. I've never seen. And it shrinks, and then you can then become an operative candidate. But in your experience, how much improvement has the field of gallbladder cancer chemotherapy and immunotherapy improved in, let's just say, 10 years?
Yeah, so I think that aspect of it in terms of treating people neoadjuvantly with chemotherapy and immunotherapy, certainly the addition of immunotherapy, which has been in that 10-year time frame, certainly increases response rates. So more people are the tumor shrinking to a degree where they can actually make it to the operating room. I think we've gotten a lot better in our management of side effects from chemotherapy. So our drugs haven't necessarily changed, but we're able to give people the doses that we want and the frequency that we want because we manage their symptoms better. Honestly, I think has a lot to do with it too. And then of course with the development of next generation sequencing and really paying attention to what drives these cancers to be cancers, looking at the DNA of the cancer itself, and the development of multiple different new drugs, especially in the last 10 years, that target the specific DNA change in the tumor itself, has allowed for even more impressive response rates and overall tumor shrinkage and how long certainly people live with these cancers. So the most common thing that we see in gallbladder cancer is a HER2 amplification, which is something we often have heard about in breast cancer, but it's in 20 to 30% of all gallbladder
This is my
cancers.
alarm's
Yeah.
going off.
Yeah.
HER2. What's
NGS.
that?
Yeah.
So
So,
HER2 is yeah.
let me interrupt for just a sec.
Yeah.
So this would be a great subject to sort of wrap it up with, which is the latest and greatest in our treatment armamentarium with things like what we're calling next generation sequencing. And so that will bring in her too. But if you could talk about what is NGS specifically and how is it, so like chemotherapy, let's just say, is kind of like a pesticide. And then immunotherapy, it's you're beefing up the police system. You're letting the body's police force, you're taking the leash off, and they can arrest anybody that even looks at you sideways. And it's good and bad. But
Bad timing, Paul.
yeah, that actually is poor timing.
Yeah.
I'm gonna just have to reach. I'm gonna have to excise that. But then NGS is entirely different. So if you could explain what NGS is and the mechanism, I think that would be a nice way to wrap this up.
Yeah. So NGS, or next generation sequencing, is a way for us to look at the DNA of the tumor itself. So we all are born with DNA, and I describe that as sort of our instruction manual. It made us who we are in terms of our hair color, our eye color. Every cell has this instruction manual to tell it exactly what it needs to do. And these cancer cells have an instruction manual that looks different than the cells in the rest of our body. And the reason that it becomes a cancer is often because there's an error in that instruction manual that tells the cancer cell to just keep dividing uncontrollably. It's not acting normally like the rest of our cells that would stop growing at a certain point. And so the next generation sequencing looks at that instruction manual and finds exactly what went wrong here and where is the mistake in that instruction manual that's allowing that cancer to grow uncontrollably. And over the years, we've developed medications. Sometimes they're IV medications, sometimes they're pill medications that can directly target whatever that mistake or error is in that instruction manual. And because these medications are more targeted or specific, more personalized, we often find that they work better because they're going after exactly what the error is instead of just being these sort of broad pesticides. And they tend to come with less side effects again because they're hitting the exact error or problem with that cancer cell and they're not hitting all of the normal cells in our body. In gallbladder cancer and in biliary tract cancer, we find that many of these tumors have one of these errors that we have a targeted medication for. And as many as a third of patients that we see have something that we can offer them a targeted, more personalized treatment option for.
So what does
That was a
HER2
great
stand for then?
explanation.
Yes. So HER2,
That was
HER2
yeah, right. That was that. I suspect you've explained that many times, but that was that was great.
oh,
That was
thank you.
great.
HER2 is one of those mistakes that we can see. It's basically a protein that sits on the surface of some of these cancer cells. And because it's a protein that sits on the outside, we can target it with a drug. So we give a drug that goes directly to that abnormal protein on the surface of the cells and somehow causes the cells in multiple different ways to be killed. And so that protein sits only typically on tumor cells and not very many normal cells in our body. So it's a direct target for that drug to go where we want it to kill the cancer cells and have less of an effect on the cells in the rest of our body.
Do all cancers have a signal like that? Are
Not
they all
all of them.
flagging themselves? No.
Not all of them
Yeah.
do. They say certainly do. We just haven't figured out what it is in all of them yet, or we don't have the target for them. But that's part of the power of next generation sequencing is we're trying to figure out what's the driver, what's making this cancer a cancer. And do we have a drug to stop that at this point? And if we don't, it's likely something that someone's working hard to figure out how to stop it.
Thank you. That was a great explanation. Even I understood it.
Well, everybody, I want to say a very warm thank you for putting all this effort in and coming tonight and creating this podcast and the show. I think it's going to be helpful for our patients and all the patients that we don't have but are out there around the world tuning in. And again, can't thank you enough. I appreciate it.
Thank you, Paul.
Yeah, thanks for
Absolutely.
having us. It was wonderful.
Thank you.